Dr. Chang, thank you for being here with us and offering this Faculty Development 103, so evaluating residents and other trainees. If you want to just take it from here and do your thing.
Thank you so much, Nicole, for having me and NMPCTC. As a brief introduction, I work with the Department of Family and Community Medicine with the University of New Mexico as one of the associate program directors for the residency program, and I've been the chair for our clinical competency committee for the past several years. And so a lot of this information is gleaned from that experience and some common tips and tricks, as well as hopefully some good reference material that I found as I was preparing this for you all. Let's get moving forward here. So there we go. What we hope to accomplish today is discussing different types of evaluation that can be used in residency education and being able to apply the best practices in doing assessments that can also be applied to more than just residents. And my hope is that those who are here today can identify one potential thing that you might change in your personal teaching strategy when you're working with residents. So in other words, in picture words, that's looking at some of the background gears, tools that you have in the toolbox, and then ways that you can stay on target or can be right in the middle of where we want to be, and then things that we can find to go do on our own, in our own practice. Okay. So the big picture stuff, this is more of a, what is the setting that we're talking about and the landscape that we're working within for this resident education business and resident evaluation is that there is overall an ACGME, right? This is the folks that outline what we do need in an accredited residency program. And then within that, there are some requirements that are common across all programs, regardless of specialty. And then there are specialty specific requirements, so specific to family medicine. And for each program, there's also what's a clinical competency committee where we look at different competencies that future doctors, future family docs should have. And these are split out into milestones, similar to how we think about developmental stages. And then there's the concept of 360 evaluations, as well as individual education summaries or individual learning plans. So, had a brief talk as we started out today to see who all was here and what would be most helpful. And it sounds like we might have some newer residency programs that are getting started, hopefully, right? And wish you all the success with that. And so some of these concepts can be helpful as you prepare and plan for how you're going to do what you're doing with residents. So first things here is, what are we focusing on today? And specifically, I'm focusing on evaluating residents. But some of the same concepts can be applied to, working with fellows, working with medical students or PA students, other trainees. Okay. And narrowing in on that, there's this concept called formative evaluation, formative assessments. And so we'll talk a little bit more about that if you haven't worked with that before. And that is in contrast to what is called summative evaluation or assessment. And then the other thing I'm focusing on is evaluation, not so much feedback. Those are two separate things, and we'll talk, some of it crosses over. I might use the term assessment interchangeably with evaluation, but this is distinct from the concept of feedback itself, which is a whole nother talk if you want to go down that route. So first things first, formative evaluation is meant to be low stakes. Have you heard of formative evaluation before?
Yes.
Yes. Okay. And when you're looking at formative evaluation, I guess, how do you perceive using that, or how have you used it?
Sorry. I feel like I'm the only one that's going to be answering here, so
I appreciate it.
Nicole, help me out. Yeah, I actually worked in education for 25 years before I started doing this, so this is not new to me, but it's helpful in that I'm actually working on a binder right now for for our faculty to prep them for our site visits. So I'm pulling together things like what are milestones and what are EPAs and what are evaluations. And so I'm working on training them. So yeah, this is all very familiar territory.
Yep. And that's wonderful. That's perfect, because I think a lot of times it's the other way around, that we have physicians, right, who have gone through all the different levels of higher education and medical school and training. And then now we're meant to teach other physicians, but some of those concepts from teaching aren't second nature, or we haven't been working with them. And so that's actually fabulous, because what I'm trying to do is bring some of those teaching concepts in to doing this work. So the idea, again, being that formative evaluation is meant to be low stakes. So it's about, seeing where is the learner supposed to be headed, right? Where are they now? And then where does the learner need to be, right? And how do we help them get there? So the idea of formative evaluation being that we're monitoring their learning along the way, helping identify, things that they need to work on, or things that they're doing great, please continue those areas. And then what things are the clear, targets that need to be addressed immediately, right? So one example of this is the 1 minute preceptor. And is this a familiar concept already?
That one I have heard of, but I don't know much about it.
Okay, perfect. So this one, it's very simple, meant to be done in 1 minute, right? And if you want to hear more about it, I think 102 or 101, the faculty development session from Dr. Stolberg mentioned some of these different preceptor methods. This one I like because, one, again, it's simple, right? So one, it's just about getting commitment from the learner, probe for what supporting evidence they have for that thought process, and then reinforce what they did well, help with any things they missed, or things that need corrected. And then the idea being to teach a general principle. And then we summarize and say, all right, what are the next steps going to be? What are your next action steps? And so it follows this same pattern, right? That where is the learner going? Where is the learner now? And how do I help the learner get to where the learner needs to be, right? So then the idea that formative compared to summative, right? So formative assessments are for learning, while summative assessments are of learning, right? And so the idea being that you have all these little building blocks and you're putting them together. But the key is that each of these is a block in itself to help the learner learn, right? And so what are examples of those? We're talking about using the competencies in having evaluations, but they might be from different sources. So whether it's faculty doing it, or peers, patients, other healthcare that we're working with, or even the residents doing a self-assessment. So all those things matter as we're helping them learn, right? Other things like direct observation, you'll see feedback is tied into that, but you have to first evaluate them before you can give feedback, right? And then objective structured clinical exams. These are OSCEs in other terms that we use in the medical education world. And then chart review, right? It's often going back and looking at how the resident wrote the note, what they missed, maybe nuances that we can suggest in the next time they do the same thing. And then that all culminates into a summative assessment, right? Where biannually we do an evaluation and we create an individualized learning plan for the resident.
I apologize for my informality a minute ago. I should have said Dr. Chang, not Kathy.
Oh, you're fine. Wait, this is a team sport, right? So doing all this work, I appreciate it. So then the basic concept being that evaluation is different from feedback, right? In order to evaluate, you need to first, or to give feedback, you need to first evaluate where the learner is. Have we heard of this RHYME model?
I have not.
No. So this is the cheat sheet, and I have all the references for these at the end for you. But the idea being that you have someone who can just observe and just watch, but can't do anything, versus someone who's able to report, so they understand what's going wrong and they can tell you that something's going wrong, right? The next level being an interpreter, so this person understands why it's wrong, not just that it is wrong, right? And then the manager can actually do something about it, and then the educator does beyond that. They're learning more as they go and educating their team as well. So you'll notice that this is you have to first assess and see where is the learner, where is the resident along these stages, and hopefully, right, they're all coming in from early medical school, maybe M1, M2 year as an observer, just trying to figure out what's going on, right? And then as a senior medical student, they should be able to report and at least know what's going on. And hopefully they're moving towards that interpreter stage. But when you're a resident, you're really hoping that they're managing the problem. They're not just saying, hey, you know, preceptor, I noticed this thing is wrong, but they're actually able to say, I think we should do this about that thing. And then as they get stronger, they can also be educating medical students, or as a senior resident, they're educating their interns and so on, and the whole team, right? We learn a lot as preceptors, even from our students and our residents. So evaluation, though, once you evaluate and assess where is the learner, it should be accompanied by those best practices, right? In giving feedback. So what are the best practices, or what things have you been trying to include as you think about, oh, I need to deliver this feedback to learners now?
I mean, all of this information is really good, and I'm the kind of person that tends to write everything down because that's the way I learn. So I'm furiously writing notes here, but I will look back at the slides and, you know, basically compare that to kind of what I'm used to, and how can we train faculty to teach better and evaluate better. And so this is all really good. Thank you.
Thank you. And I think what I'm asking is also, you know, what are things in delivering feedback that that you've heard of as, you know, these are the best practices to do? And
I feel like
one example would be, sorry, Nicole. One example would be the sandwich method: positive, negative, positive.
yes, and that's actually a classic one that has been out there for years. And there's another one that we'll talk about in a little bit called feedback with good judgment, that takes some of the best ideas, but moves beyond just the, you know, positive, negative, positive, right? And some of these things, and I'm sure we've talked about these before in other arenas, but is, you know, being respectful, right? Having clear goals and objectives, and it's based on something that we actually observed and have as an example, right? And it's something that we're giving timely. It's something that happens all the time, so it's not that out of the blue now I'm giving you feedback so they expect to be persecuted in the amount of feedback that's happening, right? Or the, you know, learner is self-assessing and allowing them the chance to say, you know, how do they feel they did, right? And then we can then reinforce and correct things, so they're continuing to do the good things, but hopefully fixing the things that, you know, needed fixing, and then or nuancing, and using some specific neutral language, action planning, so on and so forth. So this is all part of an article that I found that I will also include in the references, about some 12 tips for giving effective feedback. And what I'd like to do is go beyond that, though, right? That we need these things, but first you need to evaluate and then use these things. Okay.
A couple other things that come to mind in terms of evaluation are, I studied, excuse me, during my master's on body language and proxemics, how you appear and how people interpret your body signals, etc., and your spatial closeness or farness, or it all is relevant. And then what's the other thing I just had in my brain? I'll come back to it. Go ahead.
Yeah, what you're talking about is the learning environment too, right? And also the psychological size. And there's actually a great course, if you haven't heard of it or touched on it yet, there's a Stanford faculty development course that goes over some of these different things. I think it's available online now as well. It used to be just live, and it talks about different ways to set up that learning environment, setting up the climate essentially, and how do you raise or decrease your psychological size for the learners, so that either you know, things are heard more clearly, or that you're more approachable, right? And being able to develop that mentorship relationship with them. Thank you.
Also, learning styles are important to take into consideration.
Yes, and we will touch on some of that at the towards the end.
Okay.
Dr. Chang, really quick, in
Yes.
terms of the use of the neutral language, how do you incorporate that when you notice that, that just a grave mistake has been made? Like, how do you incorporate that and correct that without making it seem just overly negative, I guess, for the trainee?
I think that's a great one. I'm going to parking lot that. And so as we have some examples at the end that I would love to bring that. So exactly that. And let's come back to that together at the end. So thinking about, different ways that we do evaluate, that there's different formats to consider, right? And that just some ideas for what format might serve best. So in the situation where you might need to not have a sit down chat with the resident, but it needs to happen as you're going, right? So whether it's going on rounds or, and you're assessing what is their knowledge level on this diagnosis, right? As we're walking to the next patient room, or do they understand the management plan? We're evaluating the resident, but it's an informal type of evaluation, right? Another one might be clinic precepting. So let's say I'm going around and checking in with the MA pods and seeing, how do the MAs feel like the residents are doing. That's an informal type of assessment, but I'm assessing maybe how do they do in this, interdisciplinary setting, or how do they do with communication with other healthcare team members, right? I'm assessing different things, but it's an informal type of a way. And then versus formal, maybe with structured quizzes or structured in-training exams or something like that. So and then another thought is, is it verbal versus written, right? Is this something that we're chatting about in Feedback Friday, before we get down and start rounding on patients? Or is this something that's written in the New Innovations, which is a management system, and written as a formal evaluation that I'm writing down? Or maybe it's just an email saying, hey, I was just checking on that note. I was signing off on that note from clinic the other day, and I have some suggestions, right? So it's written, but it's less formal. And then another thought is electronic versus paper, right? What format works best, depending on the setting, right? So let's say, electronic, there are some great resident management systems to choose from. So New Innovations is only one of them. We just use it at UNM, and it's used widely elsewhere, but there are several other systems out there. And then, it helps collecting all the information to one place. It saves the staff some time trying to, not having to input manually all the information and collating all that to then be reviewed later. But there are some barriers. We have some preceptors that have trouble logging in to the system, or they use it so infrequently that every single time they need some tech support to get onto the system. And other things like paper can be better for example, these 360 evaluations where we want a patient or staff perspectives, and they don't all have a login to this, electronic platform, or maybe they just, it's easier if they just fill in something as they're sitting there for 10 minutes waiting, and paper is the best way to make sure that happens. So, different ways of doing it. Another way that paper could be helpful is sometimes we've heard before, and not just this place, but in just residency systems, right? That some residents are worried about punitive use of feedback by various parties. So maybe they're not getting along with one sector, or one person who is allied health professional just has a bone to pick with every single person, and so they're writing the same comment on everybody's paper, and so having it on paper sometimes allows the faculty to gather and process that information before it becomes a formal entry into the residence record. So just different options, right, for different purposes. And then, the other assertion here is that a successful evaluation system requires some basic assumptions, right? And so what I have here is a picture of the feedback initiative with the basic assumptions. This is actually a badge card that we have, and the link is there, and also hyperlinked at the end here. But the basic assumption being that everyone is intelligent, has a unique point of view, and cares about doing their best. And if we can start there, right, you get rid of a lot of the other negative feelings and potential missteps or biases, around things, and helps, as was just brought up there, with the what do you do in a situation when something clearly happened poorly, right? And well, if I can start with, everyone is intelligent, has a unique point of view, and cares about doing their best, that changes how I formulate what I say and how I address the issue, right? So related to evaluation, though, you have to have defined expectations, right? You can't start evaluating somebody if they never knew what you were evaluating them about, right? Or for. And then
Dr. Chang,
the next thing, yes.
a couple things that I noticed that would go along with this little badge card. When I'm concerned about something, I tend to say, I'm puzzled by, or I'm curious about, so that it doesn't come across as you suck.
Exactly. Right. And they have that as an inquiry, like I'm advocating for, the best patient outcome. And I'm also, knowing that you're trying to, that you care about doing your best. Tell me a little bit more about, what led to this situation, or, tell me a bit about what, has been going on, or how did this happen? Right. Or like where, can you tell a little bit more about the situation, right? And then you gain insight from the person on what led to this scenario, right?
Right.
And
I always also ask, can you help me understand XYZ?
Yep.
So that it's them telling their story instead of me assuming things.
Exactly, right. Because from us assuming that we have all the data when we don't, right? And allowing that data gathering essentially, and saying, tell me more about your, perspective of what just happened here, so that I can better understand, right? And then it could be that they did everything right and something happened poorly. That happens, sometimes in medicine, and we can work through that together, right? Or maybe it will be more clear, where you can intervene. And then, so, if something needs to happen, right, it's very important in an evaluation system to have policies in place. So, the process for reporting and allowing the resident to have due process, right? It's not just everyone's throwing the same person under the bus, but that they've had the opportunity to improve, or, the next thing is remediation plans. So, we've gone through the process of they were notified that this was a problem, and they had a chance to address it, or to remediate it if there was a specific plan needed, right? What's that process? And then it's important to follow up on that, right? And then also document. So all those things need to be in place. Otherwise, it becomes punitive with no ability for the resident to learn and grow into that wonderful, full-fledged physician out there in independent practice in a fair setting. And then there's the concept of 360 evaluations. And this is not 365 like every day of the year. This is 360 as in, take a full look around. And so it's important to have different perspectives. So maybe it's a patient perspective, maybe it's their peers, maybe it's the pharmacist, or the charge nurse on the floor, or maybe it's the MA that they work with in clinic the most, right? And in addition to just the faculty evaluations. So having the plan for how will you get that, how will you collate all that, and what will you do about it, right? So this, we're moving on. We talked a little bit about the milestones, and this is the second version that is out, revised as of 2019, and out in the world here. And have you worked much with this yet?
I have studied my brains out about this.
This is and it's intense, and we get people who love it and some that hate it. I like it because it gives me some concrete things to use as words, right? And to use in evaluation. But the fair statement to say, though, is that some competencies are easier to measure than others, right? There are some that are straightforward, right? That you've got patient care, they either can do it or they can't, right? And the EPAs, a lot of the language is around patient care. Can they do this thing? And once they've hit it, we check the box, right? They've hit that milestone. And so an example of this is that patient care 1, right? The taking care of the acutely ill patient. So can they just make a differential diagnosis for a thing, right? And next is, can they prioritize it, right? And then you can see the levels as the learner becomes more senior, right? That now they can promptly identify and coordinate the diagnostic strategies for the things going on. And it's not just one issue, but maybe multiple issues at the same time, right? And then level 4 here, that they're able to mobilize a multidisciplinary team to manage care for simultaneous patient visits, right? And our idea, right, is that the learners come in probably around level 1, and some of them may be advanced and somewhere in between these levels. But that, level 4 is the target for independent practice. Level 5 being that aspirational level, right? That sometimes as attendings, we're still at level 4 and we're not quite at level 5, but gosh, that looks like we have an example in mind of someone who does this very, very well, right? But not everyone does. And then there's those competencies that are harder to measure, right? And one of the classic ones is professionalism. And it's more of a function of how do we gather this information, not that we're not assessing for it, right? And so, one of the teaching challenges in professionalism is how do we teach it? And they did a survey, and I have this in the references of senior residents, and found that most felt they learned about professionalism from role models and just observing role models. But the problem is, right, one, hopefully we have good role models around us, but role models, mentors, you can't guarantee that they're there, right, and across all the programs. And so as a method of teaching that tends to be imprecise and lacking structure, and the recommendation is more that it's a multi-step process with multiple inputs that define, what behaviors are expected, what's not acceptable, right? And policies that, help hold people accountable to the best professionalism. And what are the consequences, right? So let me so for example, right, this is the competency page, sub-competencies here. And, are you responsible for completing your own tasks in a timely manner, right? And then can you do that when you're stressed out, right? And then can you see situations that make it hard for other people to do those things and help with that, right? So kind of gradations of these levels of accountability within this professionalism milestones. And then level 5 is you're taking ownership of system outcomes, right? And so it's a little bit harder, but if it's something that's structured in the evaluation process, right, then you have more data points to work with, and you can actually rather than as subjective as it can be, and maybe it becomes a little more objective. I witnessed so-and-so doing this thing that was in a stressful situation. So I'm writing it down, I'm giving credit for that. And then the other concept here is frequent assessments over time help describe resident competence more accurately, right? So some of the things that it helps with is that it's not as high stakes, right? So if you do these frequently over time, the learner isn't feeling like I have this one chance to show up, and if I don't, I'm going to fail, right? And also we have differences with who's doing the viewing and who's doing the examining or assessing, right? And the real world is the real world, right? And not all personalities get along. And so when you have non-standard patients, right, we don't all have an OSCE patient in every single room. And so the more often we have these assessments, the less variability you have, right? And then it's a more accurate measure of, is this something that Dr. So-and-so does all the time, or is this a one-off, right? Reduces some of that failure to fail, because as educators, we want everyone to succeed and show up at the end and fully successful. And sometimes there's a lot of pressure to not fail anybody, even though maybe they're not succeeding. Right? And then so the stress also reduces on that outcome. So basic idea, right, is that formative evaluation is meant to be low stakes. It's meant to help somebody learn, right? It's for learning. And then that summative assessment is of their learning. So then, part of the role that I think most faculty are part of in resident education and evaluation is not what the CCC is doing, though some of you may be also involved in the CCC process. But just so you can know what is it that they're doing and what are you responsible for if you're not part of CCC, is that the CCC is responsible for doing that summative assessment, right? Summarizing how they're doing overall. So some of those 3 core goals that I really like the way it was stated here, and I have the reference, is discern and describe the developmental status of each resident for the purpose of optimizing their education, right? And then how ready are they for going out onto their own in practice? And then can we foster their ability so that they take the learning and run with the baton and continue learning, because our learning is never done, right? So things that residency faculty can do that is helpful for the CCC, and we see it like a nice little package. These are the, like a present of things that we were looking for, is that if you're specific, so the more specific you can be, the more helpful it is, right? And it's based on something you saw directly. So direct observation, it's something that was addressed with the resident, whether in real time or whatever appropriate time was that, you were able to touch base and sit down and talk about it. It's written down, because if it's not written, if it's verbal, we still have to write it down so that we have something to review. This helps with things like due process, because if there's no documentation trail, right, we don't know that we gave them the opportunity to succeed, throughout their time. And then timely. So if it's too far out, we know that with, just let's say, clinical documentation, the farther away from the time of it happening, the less accurate it is, right? And at the same time, if you're real riled up about something, it might, write it and take a minute and look at it later before you submit it, right? Going back to some of those concepts, though, as Esther was saying, that is as we are working with residents, sometimes it's easy to get into the, I'm just doctoring with them, but be active with the teaching mindset, because there are very specific things that are involved in evaluation that we need to use, okay, that help with that forming their professional development, but also in that summative assessment. So using those competency-based languages. So I like that ACGME, milestones 2.0, because if I'm not sure, whether they were doing something at the level they should, I can go back and look and say, that first level was, can you do a differential on an acute issue? And then can you prioritize that differential? And then can you do that for multiple conditions, right? Or can you manage these conditions? And you can then see exactly what behavior you're looking for, and writing that into the rotation evaluations or the week evaluations, or as you're informally discussing with the resident, like, you did this thing, but I was expecting to see this, right? Then it gives you something firm to stand on using that competency-based language. And then having specific and concrete examples is very helpful. So you're actively looking and seeing them do it in context, right? This also helps when you're discussing that with the residents. So they might have a personal learning goal, and then you can look and say, in this very specific example, I liked how you, notified the team that we needed to call the, patient's wife before we went and did this thing, so that we could achieve that goal later on in the day for the patient, right? Like, you can give a specific example and they can anchor on that and know this is what you're basing your assessment on. And then this maybe should be at the front, right? Is that as you're working with the residents, start off the day, start off the week, maybe start off that clinic session with your expectations, but maybe start with the learners first, right? And say, what is it that you're hoping to get out of today? What are your learning goals for today? Or, this is your inpatient rotation. What things have you been working on? What areas do you feel like you need to improve on? And discussing those ahead of time. Otherwise, we don't want to come at them from out of the blue, right? And it's very helpful. This is a tips and tricks, is keeping notes while working with the learners. So what you're observing, what the example was, maybe what you've already talked with them about. So at the end of the week, or when you're signing off to the next attending, you can say, we talked about this, and if you can follow up and see whether they were able to make improvement, right? These are all helpful things. And then some of those common missteps where nobody wants to make missteps, but some of those things that were mentioned that we can talk more about too, we will talk more about, is things that are personality based, right? And or other potential biases, right? I remember there's an infographic out there, like 50 biases that are out there. And if you can take the example of this is if you can take the gendered pronouns out of the evaluation and you can still guess which gender this person is, maybe there's some bias in how you write it or what words you chose, right, to use for this evaluation. Lacking discrete examples. So this will come up when the resident says, I don't know what you're talking about, right? Or I disagree, with what you're saying is your assessment of my work and my performance, right? Or we don't know how to help them more. If it's been too long and it's a significant concern, right? It's better done closer to the time so that the resident has the chance to learn, right? It's fresh on our minds of why it was important, but also we're concerned about patient care and delivering the best patient care. And then not having it written down, this sense of ganging up. So sometimes we'll say everybody thinks this, or everybody's having issues with this. We want to avoid that too. Right? Because what's really important is this relationship of as a teacher, as a mentor for their professional development, we are concerned, and want to do something about this. So I have some examples. It looks like we've got a couple people to help with this. So strengths and weaknesses of this faculty blurb assessment of a resident.
That's not very helpful, honestly.
Why is it not helpful?
It's too vague. It doesn't give specific examples.
Okay. Anyone else?
Doesn't really assess their work.
Right.
Maybe it goes to professionalism, but.
And it seems like it's more personality based rather than skill based. And
yeah, exactly. All those things, right? So they were nice, like, oh, that's cool. What do I do with that, right? And like, okay, what if somebody was not as nice? Okay, right? But we can use better words to describe that situation, right? And then how do you as an educator say, this is what this person is doing well and this is what we can work on, right? Or this is these are the strengths and these are the weaknesses of this resident, and create a learning plan around this or help them achieve better, right? There's just not much here to work with, and there's potential for bias in here because looking at this, we could guess and say, who are we talking about, or is this biased because of my perceptions of a certain type of person or certain type of worker, right?
When I see the word lovely, it makes me think it was probably a woman because you don't typically use lovely for a guy, but again, that's a bias that's inherent.
Right. So, there is, they mentioned this in the medical student evaluations. This is something that comes up in, resident interviews, right? As we're looking at the letters of recommendation, right? And it carries over in the work straight into the resident evaluation. So, if a resident is wanting to know how they can improve, and this is all they get in their written evaluation, one, they may feel that you're just describing my personality and it's nice, I'm glad that you like me, but right, what can I work on professionally, right? Or it may, hopefully they don't feel bad, that somebody said it was lovely to work with you, but we can do better as educators, right? How about this one?
Much better, for sure.
What is better about it?
Gave specific information that this was a personal goal that they're working on, and gave them feedback on something they can continue to work on.
Goals, objectives. timelines. It's nice.
And I
How
think
about
there's still room for improvement, though, just to specify what it means to be to come across too strong at times. I think that would be something that could still be improved upon.
Thank you. Thank you. Yes. So all of those things, right? It's intended to be a little bit better than the previous example because there is some specificity here. And but you get something that's kind of vague, like, well, what do you mean by coming across too strong? Is that a good thing? Is that a bad thing? Like, is it personality? Is it a style? Is it the words that you're using? Is it the physical distance from somebody? What is that? What does that mean? Right. And the residents can look at that and be like, what do I do with that? And maybe they have the exact example in mind because they talked about it in the moment, right? But it's not clear from what me sitting on the CCC looking at this, what can I do with this, right? I'd have to ask for more information. Here's another one. How about this one? And I just want to say these are all made up names and made up situations based on common themes.
Well, it mentions his, so we automatically know it's a guy. It doesn't really mention if the person that wrote this addressed this directly with the doctor or they're just kind of waiting for someone else to handle it.
That's what it sounds like, right? So we get something like this and we're like, oh my goodness. We bring this up as essentially an outside reviewing body, right? On these evaluations. And is this going to sideline or not sideline, but hit completely out of the blue if we address this with Dr. C, right? And say, hey, we heard this was an issue, right? And if this is ongoing, it should be addressed in the moment, right? To leave out without signing out patients or to disappear and then come back without any explanation if you were expected back and there's work to do, right? This is something that probably should not wait until the biannual evaluation to be addressed. And so, for those who are helping faculty who are evaluating residents, right? Sometimes faculty do need the support or feel empowered to do that and address things immediately with residents. Or it might be that it was a really sticky situation and awkward, and I wasn't quite sure how to handle it. It's like, well, great. So let's talk through it together and then decide who would be the best to handle it and address it. But something like this should not be thrown into a closed door evaluation that shows up 6 months later, right? Maybe this was an email that went straight to the program director, but then it's also not written in an evaluation anywhere formally, right? And so it's sort of skirting the issue and skirting the responsibility. How about this one?
I mean, it's got the gender base, but I assume that these are, evaluations that are going to go in that particular person's chart. So maybe, using pronouns like that are not an issue. I'm not sure.
Yeah, the pronouns are not an issue, I think. My point in bringing it up was that if you are looking at the details of the evaluation and you were to take out the pronouns, does it look biased, right? Are we using the same language in assessment for people regardless of gender, right? And yeah, that is just one example of bias.
Yeah, that's a good point.
Things that you like about this, anything you dislike?
It's very specific. The things she's working on. This one seems much more clear and concise.
Good. That's the intention of this one, to say, we can be specific, have examples and suggestions and next steps maybe that we talked about with the resident, right? So more of this is more helpful, right? As you're coming back to do that summative evaluation. But you can see that this was something that is for Dr. M to learn, and we talked about the learning, and she's working on these things, right? Thank you. All right. So some of the issues that you might come across, right, as you are doing more and more resident evaluations and doing the summative, this is the summary of how they're doing, is that you end up with things like faculty disagree. What would you do then?
Scissor, paper, rocks.
So we have one more. Oh, we have another participant here. I don't know. We want to chime in. Any other ideas?
Do you bring in a neutral third party?
Right, because it really depends on what we disagree about, right? So is it that that maybe there was a personality clash, right? And we need a neutral third party to say which perspective, like find the truth within all the perspectives, right? Or maybe it's just, somebody saw this resident in one setting and they did great, and then this other setting they didn't do great. Maybe it was a bad day. What is it? What is it that we disagree on, right? And try to find that out. And a lot of times it comes down to obtaining more data. And you can say, you know what, this is highlighting an area of concern. We're not quite clear on what the concern is or what to do about it. So we need to define it better to be able to help the resident in their learning goal, right? In becoming that independent practitioner. So let's obtain more data, right? But if you're going to do that, you also have to make sure that you're following up. So whether it's following up on the reconvening the CCC, reconvening the faculty involved to make those definitions, define things more, and what do we do next, or following up with the resident and saying, this is going into a discussion on individual learning plan. What can we do, right, together to help you go to this area and why it's a concern, right? So usually the answer is more data, but don't forget to follow up. And then what about when residents disagree with your assessment?
Maybe just have a conversation with them, asking why they disagree, talking about what the faculty see, their point of view, that kind of thing.
Right, like my picture is a clue. I worked hard to find these pictures, but one of the things that you can consider is one, we talked about best practices and feedback includes not delivering feedback in the absence of a mentorship relationship or, some sort of relationship with that resident. So, is this coming out of blue? They feel like you don't have any right to say this, right? I don't even know you, right? Or are we sitting down and making sure they know that we care about you? This is for your education, for your learning, for your professional development, because we care, right? And then there's this consideration of triggers. So sometimes if somebody completely disagrees with what you're saying, it's either an issue around the truth of the matter. So they have a different understanding of the same situation, right? Like that you said this happened, but they disagree. That's not what happened, right? And so there might need to be some clarification, which also then is why those specific and concrete examples is helpful, right? Or direct observation is helpful. And then a relationship, right, around this, do you have prior issues or do you have a good relationship with this resident, with this person? And then it brings up the question of how do you overcome bad past experiences, if there needs to be a third party mediator or somebody to be able to deliver this feedback, or maybe you're not the best person to deliver it, right? And then identity. So this issue is around the self-view, self-identity. So if what you are saying is at odds with how this person sees themselves. So you might say, you know what, you are really coming across as harsh to the medical students, and I don't know that it's the most helpful or learner-centered environment or something, and they feel like, I'm a strong educator. I don't know what you're talking about. I see myself as an educator. That's one of my core values as a human. Then what you're sharing may completely, not jive and disconnect, and actually be antagonistic to their self-view, right? And so that's just something to consider, that usually if somebody is completely disagreeing with what you say, it's going to be one of these types of things to think about. So going back to some of the things that we covered, right? Some of the nitty-gritty background things of ways to view evaluation, different formats, right? Considering some of those best practices. What can you do to be in those best practices? Having those specific language, competence-based language, look for bias and being, aware of different types of biases. So whether it's gender-based or language-based or ethnicity-based or even different specialty-based, right? Or there's so many different things there. And then seen some examples of ways to write evaluations, some that are less helpful, some that are more helpful. So my question to you is there anything that you feel like you might take away? And questions. First of all, we can get back to the question that we had earlier on the situation. Do you mind sharing that situation again? We'll talk about it together.
Yeah, so it was just mainly how do you kind of check your language when you are doing an evaluation and you notice someone make just a major mistake and just kind of checking your language to make sure you don't go overboard with it.
I think going back to some of those things where go all the way back, sorry, to this feedback with good judgment, right? That going back to centering yourself around that everyone is intelligent, has a unique point of view, and cares about doing their best, right? And then starting there with that inquiry and saying, let me better understand, the situation from your point of view, and starting from there, right? And I think that cuts down a lot of the other languages because the other language choices, because I'm here for the residents' training and well-being and professional development, as well as for delivering the best patient care to that patient and their family, right? And so I would suggest we start with that.
I may steal that little card.
Yeah.
Or adapt it.
All there. Yep. So so going down to the end, sorry. Hopefully you found at least one thing that you might incorporate into your practice that might change or just be an addition into your practice. And these are some of the references from this presentation. Any other questions or thoughts around this?
Really nicely done. Very helpful. Thank you.
Well, thank you so much for having me. And I will send a copy of these slides in as well, and I can email them to you if you send me your email.
Great. Thank you so much, Dr. Chang. We really appreciate this. And we'll make sure to get this presentation up on our website and send it out to all the programs too. So I really appreciate that.
Thank you so much again for having me.
All right. Thanks, everybody.